Hi, good evening, everybody. Good afternoon. It's 8 p.m. in Paris, Berlin, 7 p.m. in London, 2 p.m. in Atlanta. And this is the Myeloma News Live brought to you by the IACH from Atlanta. And I'm Mohamad Mohty from the Sorbonne University and Saint-Antoine Hospital in Paris in France. And it is my great pleasure and honor to welcome our two ambassadors, our two reporters, two journalists, two top experts in myeloma, Professor Irene Ghobrial from the Dana-Farber in Boston, and Dr. Salomon from the Lille University Hospital in France. And this ASH 2021 is quite amazing. It is a true revolution currently ongoing in the field of myeloma. This is why the IACH steering committee felt that it is really mandatory that we needed to have the hot news live directly from ASH. So yesterday we had several oral sessions. We had an educational session about myeloma. Today we have just finished session 653, the oral session, and Salomon and Irene have kindly accepted to bring to you the latest news from ASH. And I will try to structure this because we're going to have two broadcasts, this one today and tomorrow, same time, 8 p.m. Paris time, 2 p.m. Atlanta. So we'll structure things. And of course, there is some embargo on some presentations. So today we'll deal exclusively with everything that has been presented on Saturday, yesterday, but also today up to 2 p.m. Time of Atlanta. So my first question, ladies first, and let's start, I would say, by the precursor conditions. Irene, what are the latest news about MGUS and smoldering multiple myeloma at ASH 2021?
Yeah, so thank you, Mohamad. It's really a pleasure to be here with everyone. And just remember that it's such an exciting time to be live in Atlanta, despite everything and despite COVID. Here we are, we're all alive, we're all vaccinated, and we're all very happy to be back in person. I have to say that Precursor this year was a big hit. And indeed, it was some of the biggest studies that are being presented. The iStop study from Iceland, where they screened 75,000 people, almost half of the population. And of course, we presented our PROMISE study, focusing mainly on the Black Americans and the people who are at risk, meaning family history with multiple myeloma. There were beautiful other studies of MGUS-like by Bruno Pavia. There were so many other things on large cohorts on amyloidosis and long-term follow-up. So it was a session about precursors and should we screen for the first time or not people with myeloma. And I would say, all of us.
Irene, everybody is speaking and tweeting about this iStop myeloma study from Iceland, but also your own contribution. Can you give us a little bit more details to our colleagues who are not able to follow or to attend, because there are so many lovely sessions at the same time about this amazing study. A full whole country was screened for a plasma cell dyscrasia, I guess.
Yeah, absolutely. I mean, if you start thinking about it, should we really screen for multiple myeloma? And the question is, we see many patients with myeloma, but by the time we see them, they are symptomatic. They have already end organ damage. And how can we change that completely? How can we rethink the way we think of cancer and try to prevent it by early detection and early interception? And the first one was the iStop study, where they screened half of the population. It's just impressive how much you can screen the whole population or half of the population of one nation. They found that 5% or so of patients have, 4% have monoclonal gammopathy of undetermined significance, 0.5% have smoldering myeloma. This is the first time we have the true prevalence of smoldering myeloma in a population. And it's a long time for us to see what are the long-term outcomes of those patients. Today, we're seeing more about the light chain assay and how you can improve on it from the iStop study. Yesterday, we heard more again about the COVID-19 data from the same team, but it's going to be a wealth of data. I think the most exciting part of that study was the randomization into 3 arms. So what they did is they screened half of the population, 75,000 people. They got to know by serum protein electrophoresis and serum free light chain if they are positive or not. If they had almost myeloma, more than 3 grams protein, or a light chain ratio over 100, then they told them about it and they put them aside. But the people who were MGUS, they randomized them into 3 arms. Either you do nothing and you don't tell them about it, which we were talking about it yesterday. Here in the United States, you may not be able to do that, but in Iceland you can. The IRB allowed them to do that. The second arm was you follow them, but based on IMWG criteria of you don't have to do a bone marrow, you don't have to do imaging, and you just see them once a year. And the third arm was more intensive diagnostics, more imaging, more bone marrow biopsies in everyone. And it was impressive. They've done over 2,000 bone marrow biopsies in those patients. It's just beyond amazing how much data they can do with all of these large cohorts. But the most exciting part is if you do more diagnostics, you will identify early smoldering myeloma, amyloidosis, lymphoproliferative disorders, Waldenstrom. And there was a lot of questions whether this is just a bias and you're, migrating into an earlier diagnostic criteria. But I think we are now starting to say it's important for someone to know early because it does matter and it empowers patients to know that they have this early precursor lesion and that it may go on to myeloma. And I think the next steps will be, how can we prevent it? How can we really make a difference in that study? Now, our study was slightly different because it was asking the question, should I screen high-risk population? So in Iceland, they don't have too many African population, they don't have too many Blacks, but here in the United States, it's a diverse population. And we asked the question, can I look at either Black Americans or people who have a first-degree family member, because you are asking the question of, should I screen certain people, not the whole population? And interestingly, we used the mass spectrometry by binding site, but we were able to apply for the first time their artificial intelligence so that you can quantify it at a very low number. And what we found is, if you think of the general population over the age of 50, what we've learned from Dr. Kyle, that you would have a 3% prevalence, our numbers were by serum protein electrophoresis, it was 6%. By mass spectrometry, it was 40% of us walking around over the age of 50 with a monoclonal gammopathy. And that was a shock for us to see those numbers. We found that the ones that are above a certain level, what we called mass spectrometry MGUS, which is the level that you would rather detect by SPEP, these were 13%, but anything below that, but it's still quantifiable and still confirmed by LCMS, we termed it, or we coined the name monoclonal gammopathy of indeterminate potential, which is similar to CHIP. So MGIP is the new CHIP, as I say. And we're now trying to ask the question, what does it mean to have all of those early monoclonal gammopathies? Do they really reflect a precursor to MGUS and myeloma? Are they increasing our chances of cardiovascular diseases, just like CHIP is? Is it an immune dysregulation, an immune fitness issue? Is that a reflection of inflammation? So lots and lots of questions to be asked in the future, but it starts to open for us all of those biological questions of, many of us are walking around with precursor conditions, and it would be interesting to know what are the implications of that in the future.
This is really amazing because at the same time, while we're talking now, you have the plenary session ongoing, and one of the presentations is about CHIP protecting against Alzheimer's disease.
Yes.
So I don't know whether it's a good or bad news. You may get a cancer, a hematologic malignancy, but then you keep your brain clean, no Alzheimer, or the other way around. Salomon, you were not involved in these studies. Are you convinced that maybe we should start screening for these plasma cell abnormalities or monoclonal gammopathies? Because it looks like to me the field is trying to detect them early, and this is maybe where we will be able to eradicate them. And we'll speak about immune therapy, because immune therapy works best when you have the precursor disease. What's your opinion?
No, absolutely. I'm totally convinced. And, for basically two main reasons. First, we see too many times patients that arrive at diagnosis of multiple myeloma with already, some end organ damage, and they can be like severe. Patients are on dialysis or, have severe bone lesions. So if we can prevent, this diagnosis complication, that of course would be something very interesting. And the second reason is also because we have the chance with multiple myeloma to have something very simple to test, right? To have the diagnosis, a simple MSPEP, or even the new generation of mass spectrometry that are, easy to perform, as Irene just said. So it's easy to get this diagnostic, and we can prevent this complication at diagnosis, and perhaps again we can ask the question of early intervention and even improve their outcomes. So I'm fully convinced.
So one question we have from the audience coming frequently, Irene, assuming we would like to go into an early intervention, are you in favor of a sort of a total therapy like our Spanish colleagues are doing in high-risk smoldering myeloma, or you would rather a more gentle therapy like the IACH trial? Where do we stand? And maybe the truth is maybe in between.
Yeah, and I think we need to think a little bit of the biology and what's causing progression. And we need to risk stratify patients in a much better way, because over-treating or under-treating patients is wrong. And smoldering myeloma is such a heterogeneous area where some people are more MGUS-like and may progress very, very slowly, and we should not be treating those people. There are some people who are basically already myeloma. They just have not developed the fracture or the anemia. And for those people, under-treating them may not be the best approach, because you're not giving them enough therapy, as we've learned from myeloma. So I think, one, we need better risk stratification, and we are already seeing that the 2220 is a good model, but we need to improve on it. We need to add genomics, we need to add dynamic factors, so that you're not looking at a snapshot at a one time for that patient, but rather looking at their whole picture and giving a better assessment. The second thing I think is we're also underestimating all what we've learned from in myeloma, and we're going backwards. So what have we learned from myeloma? That multiple drugs work better, that immunotherapy works better, that precision interventions work better, that an 11-14 patient is not the same like a 17p deletion. And we don't want to go backwards 20 years ago and restart all of this in smoldering myeloma. Let's take that knowledge and bring it in, which means let's bring immunotherapy as early as smoldering myeloma. In fact, it may work much better there. And indeed, we will be opening the first platform study of multiple arms of bispecific antibodies in smoldering myeloma. Let's bring in questions of 11-14 translocation. And indeed, we're bringing in venetoclax in the smoldering myeloma setting. Let's bring in, for those that are almost myeloma, 4-drug regimens. And indeed, there is the KRD transplant by MyReV. We're doing their RVD, so the Griffin-like study. And we will answer those questions, whether those are the right drugs. And then for those people who are not extremely high risk, where there's still high risk myeloma, 3 drugs may be the best ones. And here we have the ISACA study with isatuximab Lendex versus Lendex, or daratumumab Lendex versus Lendex. So lots of questions that will be answered soon. But I think, again, the new way where we're going to think of what is myeloma, it's going to be smoldering myeloma. We will likely be treating almost everyone early on. We're already doing that when we change the criteria. And I think as long as we're careful not to over-treat people, there is something unique about treating someone early before they have a fracture, before they have kidney failure, because that's just miserable to have comorbidities that are associated with it, and then you're starting treatment. So definitely we need to think in a different way.
Fantastic. We need to cover other topics tonight, but definitely we will discuss all of this in depth in the post-ASH debate we will organize in a couple of weeks. And definitely we will invite you, Irene, to continue these deep thoughts on how to handle early stage disease. Let's move now to MRD, because we heard a lot about MRD. We heard the Griffin data and the amazing, actually, MRD level. Less than maybe 90 minutes ago, we heard the HD7 study presented by Dr. Goldschmidt about the isatuximab VRD induction in the transplant eligible patient. And the primary endpoint was MRD, actually. For the first time, you have the first randomized phase 3 trial with MRD being the endpoint. And there are a few other trials. So, Salomon, what are your thoughts about the MRD, let's say, latest news from ASH 2021? You know, things that are still fresh in your mind in the last 24 hours.
Yeah, right. So indeed, we had, data on MRD on very important trials. You mentioned Griffin, this phase 2 trial that, but we have a long update here after 2 years of maintenance. So Griffin is this phase 2 that was run in the US with DARA VRD autograft transplantation, DARA VRD and DARA LEN as maintenance versus all VRD and LEN maintenance. In the control arm, 100 patients were included in each arm, and now we have a kind of long-term follow-up with a little bit more than 3 years of follow-up. So we had the updated data on MRD response and MRD. It's quite impressive because we have 64% of patients receiving DARA that reach MRD negativity versus only 30% in the VRD group. So that's a significant difference, but also they looked at the sustained MRD negativity. And you know that MRD is one thing, but we truly think that what will be the best probably prognostic marker is the sustained MRD negativity, probably at 12 months, which is the best time point that we have today. And the sustained MRD negativity is 44% versus 13% in the patient receiving DARA or no DARA in the trial. So it means that almost half of the patients with this combination of 4 drugs, including DARA frontline, are in MRD negativity for a sustained time of 12 months, which is something very impressive. And we know that this correlates very well with a good outcome and a good prognostic in terms of PFS. Those patients have a very good outcome. So I think it's important data. We've seen also in Griffin that we start to have a PFS difference. It's a trend because it's not, strictly reaching significance.
But the curves are diverging, actually.
Exactly. They are truly diverging. The hazard ratio is truly in favor of DARA. We need to know that the trial was not designed, was not powered to, for PFS, but only for response rate. So there is not enough patients. But with this long follow-up, we start to see this PFS difference. So that's very important because it's probably the next standard of treatments that we will have. And we know that the Perseus phase 3 trial is, finished to recruit patients, and perhaps in the coming years we'll have data and have a true approval in Europe, because it's already approved in the US. So that was one thing. We also had, as you mentioned, the MRD data on Cassiopeia. So same trial, but instead of DARA VRD, it's DARA VTD. We had previously the data on PFS that is very significant for the DARA, but we had here the results on the sustained MRD negativity, and we had 1 year sustained MRD negativity and 2 years also sustained MRD negativity. That was interesting. And you can see that when you add DARA in induction and consolidation, you improve the sustained MRD negativity. So at 1 year, it's 55%, and 2 years, it's like 35%. It's significantly more than patients treated with VTD. And also with the maintenance phase, DARA versus observation. At that time, lenalidomide was not approved for maintenance, so it was observation. You also improve the 1 year and 2 year sustained MRD rates by a significant difference. So that's something very interesting as well. And the last big trial frontline was the GMG HD7 of our German colleagues. And it's like using, in this case, isatuximab with VRD. And so with autograft transplantation and then maintenance with isalen versus the same regimen without isatuximab, and 300 patients each arm, and same primary endpoint was MRD, and we see that there is a clear difference in that statistically difference with 50% of MRD negativity after induction, 6 cycle of ISA VRD, 50% of MRD negativity versus 35 with VRD alone. So that's something important. I think we'll have more and more MRD evaluation, even in routine practice in the future. We clearly demonstrate here that it has a great prognostic value. Now, I think the next question is, can we adapt the treatments based on MRD? And for this, we will need to wait for the future ASH conferences.
So let me ask this question actually to Irene, because yesterday we had a very, very animated, I would say, hot debate between Sagar Lonial and Saad Usmani about the value of MRD. And Sagar was absolutely atomic against MRD, saying, well, I don't care, to make it simple and short. So what are your views about the situation? I mean, Salomon, of course, alluded to the fact that we don't have yet MRD as a tool to guide the treatment. But what are your thoughts? Because for me, when I look to the shape of the curves from Griffin or from the HD7 trial, it looks like it is the way to go. Although, of course, we need some confirmation and we need trials, but sometimes some gut feeling can be useful. What do you think?
Yeah, I mean, the data speaks for itself. If you see MRD, sustained MRD negative, and it correlates with an improved progression-free survival, and it does make sense. The deeper the response, the better, and the longer the remission. So it made biological sense. The data speaks for itself that it actually gives you a prognostic relevance, and we will likely use it to change therapy as we go on in the future. We just need the data, but we know that it probably will matter, because biologically it matters. And if you think about it, MRD is just a new CR. It's the depth of response, and that's what you need. You cannot achieve cure unless you really get rid of all the cells. And you cannot say, I got rid of all the cells, until you can keep measuring it deeper and deeper. So I'm not sure we can argue, we can be very good debaters, but the science is the science, and we can, believe in it or not.
Well, I mean, what you're saying sounds like music to my ears, Irene, because I had this comment actually from a patient who is like a normal guy. He's not an expert and so on. And he used to look into Dr. Google, on the internet. And he told me, Doc, why in your expert community, you're debating so much about MRD? For me, if I can get rid of all my cancer cells, that's good news. So why are you hesitating? So we really need to figure this out. Time is running, so we have to move now to the other major topic at ASH 2021, and this is about bispecific antibodies. So we heard about cevostamab, we heard about talquetamab, alone or in combination. We heard about the Regeneron 5 something, I forgot the code. We heard about teclistamab. We didn't see a communication, but of course we know the development is moving rapidly, elranatamab. So Salomon, what's the take-home message? Because it looks like they have raised the bar very high in relapse refractory, now above 60%. And anything below, we don't want it.
Yeah, right. We now get used to this very impressive data, I guess. But indeed, this ASH is a little bit a confirmation of the place of those bispecific antibodies in the treatment of multiple myeloma. So try to, won't get into the details because it's too many presentations, but try to summarize. So we've seen updates on BCMA targeting bispecific antibodies. So teclistamab with 165 patients, that's impressive. We start to have data on PFS and duration of response. So in the teclistamab update, we know that the PFS at 9 months is 58%. So we start to accumulate this data. We had, as you said, the Regeneron BCMA on phase 1 dose escalation. Very good response rate, 75%, low rates of CRS, which is interesting, so well tolerated. So these are the BCMA. We also had bispecific antibodies with other targets, and that's very important because now we have more and more BCMA targeted therapies, so we'll potentially need to use other antigen to targets in the future. We have cevostamab, it's a bispecific targeting CD3, of course, but FCRH5, another target. It's a preliminary data, phase 1 dose escalation, late stage patients, but it seems to be well tolerated with CRS and usual side effect that we see with bispecific antibodies, but nothing much added to that. And the efficacy is still on small doses, and they are still escalating the dose. But we still have 57% of overall response rate and 33% of patients with VGPR beta. So that's good. Indeed, we had also an update on talquetamab. They use the usual weekly, so it's bispecific targeting GPRC5D and CD3 and other targets. We have the usual schedule weekly, but they also explore a higher dose, 800 microgram per kilogram, but every 2 weeks and not weekly. So that was also interesting, and same, we have a good response rate, and the toxicity that we knew with CRS and a few ICANS, also the skin toxicity and the mouse toxicity with GPRC5D. So this will be something that we will need to learn to manage. And very interestingly, as you mentioned, we had the first data on the combination of bispecific plus, in that case, daratumumab. So we had an oral presentation on talquetamab plus daratumumab. It's the TRIM2 study. It was only 29 patients, but we start to have data. Here again, they try to explore different schedule and dose, but it seems safe and the response rate are good. And we don't add toxicity when we add daratumumab to bispecific on those small number of patients. And we also had a poster yesterday with teclistamab and daratumumab, small number of patients, but same, it seems to be safe. So these are ongoing, and it's potentially the future of those bispecific antibodies to be in combination with other drugs of multiple myeloma.
So it looks like that the bispecifics actually are the new thing in hematology, not only in myeloma, because in lymphoma, they are all over the place. Now in leukemia, they are coming. So Irene, do you share the same enthusiasm? And are we going to bring these bispecific antibodies to all the currently available regimens and simply just make an add-on, or what are you feeling? How are you going to position them? Because of course we can say, oh, there are so many under development, the competition, and who's going to make it at the end. But my message is that let us develop everything, and we'll find a niche for every drug. So what do you think?
Yeah, I totally agree. Until we have a cure for myeloma, bring it on and bring all the drugs, and we will find something for them. I totally agree that immunotherapy is here to stay, whether it's CAR-T, bispecifics in the future, trispecifics, and other targets. And it can be T-cell engagers, it could be NK in the future, and so on. So lots of options for us. And I agree, it will be very interesting to start combining them together, because that's the beauty of it, that you can add it to other regimens, RVD, daratumumab, and others, or you can even have it as maintenance and other methods of therapy. So making that immune system, harnessing the immune system for your own response in multiple myeloma and deepening the remissions will be impressive. And already in relapsed refractory myeloma, we're seeing 60%, 70% responses. I mean, think about when you bring it up front, what will the response rate will be. So it's exciting time for us to see what bispecifics can do with their toxicity profile that's much better than CAR T, and it's easier to give it. You can do that in the community oncology. So you don't have to wait and bring the patient into a specific center that knows how to do CAR T. So it will open up the door for so many patients to get access to it.
Fantastic. That was really a wonderful conclusion. And obviously, I think we have never been so close to try to optimize these regimens and develop a cure for a great number of myeloma patients. Unfortunately, there'll still be some patients who will continue to relapse, but this ASH 2021 is about advancing science, about bringing hope and lots of cure. We thought that will take only 30 minutes, so we still have 1 minute. One last comment, Salomon and Irene.
Well, my comment would be, you know, what Irene said. Initially, we are very happy to be at ASH. Sorry for the one that couldn't make it, but it's very nice to, you know, to again meet colleagues in person and to be here. We had to be in a room to be too connected, but it's very alive. Actually, there are many people, and it's a great ASH, and it's good to be back.
Well, fantastic, guys. So we'll meet you tomorrow at the same time, 8 p.m. Central European time. 2 p.m. Atlanta time, but the ASH meeting didn't finish despite the time difference. And if you are excited about multiple myeloma, I would kindly invite you to attend, whether in person or virtually, session 704 in hall C2, C3. This is the CAR T cell session in multiple myeloma, and I will be very honored to share it with Dr. Malvi Savani. So see you in a couple of hours, guys, for this beautiful session, and you will hear a lot about the cilta-cel updates, some academic CAR T cell product from Spain, but also other constructs coming from the Chinese colleagues. So Salomon, Irene, thank you very much. I wish you a beautiful, lovely, very fruitful event. Please say hello to all our friends on site. And of course, please stay safe and keep well. And thanks to all our audience. Thank you for joining and for being loyal to the IACH activities. Thank you very much and see you later.
Bye.